Welcome to our third nurse webinar of 2018 entitled Nursing Solutions, the Parkinson's Community and Spirituality. These nurse webinar series showcase the work of our nurse scholars who completed the Edmund J. Safra Visiting Nurse Faculty Program at Parkinson's Foundation. Today's webinar features Dr. Diane Reynolds, former Associate Professor of Nursing at Long Island University in New York, Dr. Amy Rex Smith, Professor of Nursing at Belhaven University in Mississippi, and Dr. Lourdes Santoni, an Advanced Practice Neuroscience Nurse at Actify Neurotherapeutics and a member of the International Medical Committee for Lourdes, France. You will hear more about each of our speakers shortly. First, a little housekeeping. The PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the Parkinson's Foundation webpage highlighting this talk, or on the page you are looking at to the left. Health professionals can earn one free CEU through the American Society on Aging. Participants will receive an email after today's webinar with steps on how to collect the one CEU. You have just 30 days when the CEU is available, that is, until November 9th, to collect the free CEU. While all nurse webinars in this series are archived on our website, CEU credits are only available for the first month. In way of introduction to our program today, I'd like to just kind of introduce the concept of spirituality. Spirituality is the aspect of humanity that refers to the way the individual seeks and expresses meaning and purpose and the way they experience their connectedness to the moment, to the self, to others, to nature, and to the significant or the sacred. This is in contrast to the concept of religion. Religion is a cultural system or an institutionalized system of attitudes, behaviors, and practices. And you will hear these themes and definitions integrated into the talks of our three speakers today. Our objectives for today: at the conclusion of this webinar, the participant will be able to discuss the existing literature on spirituality, contemplate how uncertainty in illness theory relates to Parkinson's disease and spirituality, and understand the role of nursing in spiritual assessment and reference tools available. It is my pleasure to introduce our first speaker, Dr. Diane Reynolds. Dr. Reynolds is a recently retired Associate Professor of Nursing at Long Island University, Brooklyn, New York. She holds a doctoral degree from Teachers College, Columbia University, and is a 2016 Nurse Scholar of the Edmund J. Safra Visiting Nurse Faculty Program at Parkinson's Foundation. Although Dr. Reynolds is retired from her tenured position, she continues to work at Long Island University as a community member of the Institutional Review Board and as an educator for live reviews for nursing students preparing for their state licensing exam. Her interest in spirituality has directed her writing of several publications, a recent one being Spirituality as a Coping Mechanism for Individuals with Parkinson's Disease, which appeared in the Journal of Christian Nursing. Welcome, Dr. Reynolds.
Thank you, Gwen. I'm delighted to be able to participate in this webinar and speak about this very salient topic. So let's begin by looking at complementary therapy. So for purposes of this webinar, complementary therapies are defined as remedies that are used in addition to standard treatment. You may also hear the term integrative medicine to describe this. So for example, yoga, music therapy, meditation, physical activity, things like acupuncture, just to name a few, are considered complementary therapies. On the other hand, alternative therapies describes remedies that are used instead of standard treatment. It may include complementary therapies, but the difference is that alternative therapy is used instead of conventional or standard treatment. And it has been shown that many patients report the use of one or more complementary and alternative therapies at some point in the wellness-illness trajectory. Per the National Health Interview Survey that was conducted in 2012, 33.2% of U.S. adults used complementary therapies, and spirituality is an example of a type of complementary therapy. Gwen provided definitions of both spirituality and religiosity at the introduction of the webinar, but from my perspective, many patients who have lapsed from formal religious practices seek something to hang on to during times of crisis and may renew their faith. So for many patients confronted with chronic illness, spirituality and religiosity become important resources for coping. These and other references will be available at the end of the presentation. So spirituality has been identified in the literature as a coping mechanism for dealing with chronic illness, but a paucity of information exists in the applicability of this modality to those living with Parkinson's disease. I became interested in spirituality many years ago when I was a clinical instructor on a medical surgical unit, and we were assigned to a woman who had metastatic breast cancer, and she was agitated due to uncontrolled pain. She had a Bible on her nightstand, and I asked her if she would like to pray. Well, her face lit up, and she said to me, "Oh, please, darling, let's pray." So I asked her to lead the prayer, and she began reciting an Our Father, of which I was very familiar with, and I saw just a calm come over her. It was very, very powerful to witness. So through my work as a Sopra Nurse faculty scholar, I decided to research spirituality and its relevance to Parkinson's disease, and found that a gap exists between Parkinson's disease and spiritual coping specific research. There were very few studies that explored how persons with Parkinson's disease rely on faith and use spiritual practices as a means of coping with their disease. There's such a paucity of information out there. You'll notice that my colleagues who will speak after me, we have some common references because there's just so little out there. If you do find in the literature, what you will find is that really the focus on the social support and the needs primarily of the caregiver. So I've cited 3 studies here that support the use of spirituality as a means of coping with Parkinson's disease. And Bingham and Haberman posit that practices such as praying, being hopeful, depending on faith, provide a means of defining and also managing Parkinson's disease. There's a reliance on faith to discover a deeper meaning in self. You'll hear a lot about this, trying to make meaning out of the disease, and my colleague will speak to that. Also, spirituality can aid the ability to cope with the social isolation and stigma that may accompany Parkinson's disease. So the National Cancer Institute provides us with a guide for spiritual assessment areas for patients facing chronic and or terminal illnesses. Ask, do you have a religious denomination, if any? Does the patient have beliefs or a philosophy of life? Do they practice important spiritual rituals? Can they use spirituality or religion as a source of strength? Are they part of a community of support? Do they use prayer or meditation? Have they lost their faith? Are there conflicts between spiritual or religious beliefs and cancer treatments? Are there ways in which the healthcare providers and caregivers can help with their spiritual needs? Do they have concerns about death and afterlife? Do they have plans for the end of life? This may seem like a laundry list, but it may be helpful just to identify 2 or 3 questions that can be used as a springboard to initiate a discussion. But I think the takeaway here for me is reflect on your practice or your teaching and be mindful that spirituality and or religiosity can support patients as they strive to cope with living with Parkinson's disease. Here are some references that you may find helpful. And again, you'll see that Herman's name appears several times, and there aren't a lot of resources out there, but hopefully through webinars like this, we will be able to expand on our knowledge and help these patients with Parkinson's disease with another coping mechanism in their toolkit. So I thank you very much for your attention.
I'm going to be talking about Michel's uncertainty and illness theory and applying it to spiritual care of folks with Parkinson's disease. The first question, of course, is why use a mid-range theory? And mid-range theories, they don't try to explain everything about everything, but they just try to explain a small piece about what's going on. And when I had the honor of being a member of the software faculty group, we did this deep dive, of course, into all of the physiology, pathophysiology, pharmacology, et cetera. But the thing that really touched me was the stories of the people with Parkinson's disease who came and spoke to us and talked about what it was like to have that human response to this particular diagnosis. And one of the words that kept coming up was the word uncertainty. And that just put me right connected to the uncertainty and illness theory of Michel. And I thought, well, would this be a good theory to use to kind of explain what it's like to have the experience of Parkinson's disease? So I want to talk a little bit about Michel and her theory, and then talk about spirituality and how these two intersect. So Michel developed this in 1988, and it was really complicated. It was schematic. It was systems theory, and it had a lot of boxes and a lot of things that she was trying to define everything, because she was trying to predict and control this idea of how you dealt with uncertainty and illness. And it was very mechanistic. And what was interesting was within a couple of years, she reconceptualized this, and she embraced chaos theory, and she developed open systems, and she began to understand that uncertainty might be something that's never resolved. Her first idea was we resolve uncertainty in illness, but her ongoing idea was sometimes uncertainty is not resolved, and I think that's very true of the Parkinson's experience. So her basic ideas are that chronic illness creates disequilibrium, and that people incorporate continual uncertainty and they try to find new meaning in their illness. And they do this, they develop a new view of life because they integrate continual uncertainty into their self-structure. And uncertainty actually becomes their natural rhythm of life. And in the next slide, I'm going to show you the reconceptualized model. And you can see how parsimonious this is. Time moves from left to right. She had danger and opportunity in her original model, but uncertainty is moving through. And what happens, you can see there's an erratic pattern. And then as one achieves equilibrium, this circuitous process emerges and one achieves equilibrium with the uncertainty. So I want to talk a little bit about spirituality and uncertainty and illness, because spirituality has to do with finding meaning. The domain of spirituality, of course, is that which we cannot explain, the existential. So spirituality provides ways for us to attempt to understand the unexplainable, and illness experiences often raise issues of spiritual concern. When folks get diagnosed with a chronic illness, often they undergo a spiritual search, and my colleague already alluded to this. But sometimes it's even the why me variety. And this idea of uncertainty in illness requires this multiple coping skills that I talked about that first came out in an erratic pattern and then moved into this circuitous process. And you emerge with a new equilibrium. Danger as the initial threat, and identifying that danger and then helping patients in their illness trajectory to be able to move through the process into actual opportunity. So we have some spiritual care issues that are of concern to nurses, things that are within our purview that we can focus on. We care for the person. The patient is more than a patient. They are a total person. We care for their body, mind, and their spirit. I found in my experience that nurses can be tone deaf. The patient can give a cue, and if the nurse isn't aware and is listening for the cue, they can miss the patient's cues, especially around spirituality, especially if they're not listening for them. Often our standards of care do include spiritual assessment. We have some great examples of spiritual assessment in the last talk and the one coming up. But often in the hospital, it doesn't move beyond what religion are you and do you want to see the chaplain. That's the end of spiritual assessment. Now, there are nurses who develop expertise in spiritual care, and I think the 3 nurses presenting today are all in that group. We're nurses who are comfortable with their own spirituality, so we can accompany the patient on their spiritual journey wherever it leads. And you will find on your unit, you'll have certain nurses that have this expertise in spiritual care. And I think the uncertainty in illness theory does help to explain the journey that patients undergo. Now, we have already talked about the difference between religion and spirituality, and this is like the 3rd time, so you must know that it's really important. I always tell my students, if I'm saying something more than once, that's because it's a really important concept, and it's really important to understand how the discipline of nursing looks upon spirituality and religion, because this is not true in other disciplines. Psychology and medicine, some of the other disciplines, they use it as one construct, and they call it RS, religion, spirituality, and they treat it as if it is all the same. But the discipline of nursing does not do this. In nursing, we understand them as 2 separate. They are overlapping concepts, but we understand them as different concepts. So spirituality, the nearly universal trait by which persons seek hope and meaning in their lives, we see that as present in all persons. And then religion, which are the teaching and rituals of faith traditions, they may or may not be part of a person. So that's important to understand, because if you read the literature broadly and you're reading outside of the discipline of nursing, you will see this. Now, Parkinson's disease, of course, is going to be our exemplar here in terms of what's going on with the idea of uncertainty and illness and the idea of spirituality. So the overall disease trajectory, as we know, is progressive, and this is true in many of the chronic neurological degenerative disorders. There's many decisions that have to be made about treatment options, and people make those decisions along the way. And just deciding about a treatment option contains a certain amount of uncertainty. And then there's the whole issue of the vicissitudes of the daily symptom presentation and how those daily symptoms are managed. Even folks that have really great treatment plans and really good control, there still is a lot of uncertainty on whether it's going to be a good day or not. Patients find it really difficult to make plans. They don't know if it's going to be a good day or if it's not going to be a good day for them. And this is beyond even the on-off phenomenon, because that's neither predictable nor controllable. So even on a good day, symptoms can intensify and plans may not be able to be followed through on, and that can interfere with planned activities, which of course leads to a lot of uncertainty. So Herman's ethnographic study of folks with Parkinson's disease was already discussed, and I'm going to just give you some quotes from that, because I think the patient's quotes from the qualitative study are really powerful, and these are quotes that have to do with God, have to do with uncertainty, so they really hone in on this topic. So one of the patients says, so I live with Parkinson's on a daily basis. I have to adjust my times, do it, daily activities, slowly, or do it differently. I don't know how my disease is going to progress. I don't see the uncertainty. Another subject in the study said, I surrendered to him, God. Without him, I would have just given up. I know I would have not been able to accept that I can no longer work like I had always done in the past. And then another participant, so number one is to serve God. My relationship with God is really what gives me the daily strength. So as you are well aware, in qualitative studies, usually themes emerge. And one of the themes that emerged in Herman's study was this idea of reconstructing self. And it was the term she used for both the process of that happening and the end point. And she talked about struggle with dealing with the uncertainty and the fluctuations. She found significance of spirituality and reliance on faith. She found that spirituality was a factor that supported the process of releasing the old self and being able to embrace this new self. And she also found that surrender and trust in God were critical to discovering and accepting the new self. So I have a list here of some spiritual care nursing interventions that I've suggested for people that have Parkinson's disease. And these are taken from the evidence-based interventions. A lot of this is based on Beth Taylor's work out of Loma Linda. Also, the American Association of Critical Care Medicine has a list of recommendations, and there's a big chunk of spirituality recommendations on that. So here they are. Herman suggests that assessing and supporting spirituality is critical for persons with Parkinson's disease. Uncertainty and illness model helps to explain the journey. Ask, where is this person, where is this patient in their Parkinson's disease journey from danger to opportunity? Are they in the erratic responses phase, or have they settled into coherent rhythms? Through our initial and ongoing spiritual assessment, the needs will change with time, and spirituality can change with time. And I want to really emphasize that the spiritual assessment is not just a one and done, but it's something that is ongoing because people's understandings are changing, and you must be always assessing them. Acknowledging that many persons find a deepening of their spiritual self. Even as the physical self is failing, the disease is progressing, often the spiritual self is deepening. We have the gift of listening as nurses, being fully present to the other. That's a really gift in our culture because that doesn't happen in very many places, but it happens between nurses and patients. You can read sacred scripture as you are requested. You can make time and space for the patient's spiritual practices. You can always make referrals to chaplains and to faith community resources. And then this was already mentioned very nicely, but this idea that you can pray with a patient if the patient requests, and there is actually evidence that does support this. So I think my references are next. They are, and I'm ready. Thank you for your attention and your time.
Thank you, Dr. Smith. I'm aware that our introduction for you did not come through on the audio, so now that you've completed your talk, I'd like to just say that Dr. Smith holds a doctoral degree from the University of California, and she's professor and director of the RN to BSN online program at Belhaven University in Jackson, Mississippi. Her program of research is on spirituality and health, and she's a contributing editor for the Journal of Christian Nursing. Dr. Smith is a board member and the secretary for the Nurses Christian Fellowship International, and she's taught courses on spirituality in the United States, Philippines, Fiji, Chile, and Nigeria. She was a 2016 Nurse Scholar of the Edmund J. Saffer Visiting Nurse Foundation, Visiting Nurse Faculty Program at the Parkinson's Foundation. She's also author of a well-known chapter, Communication in Life-Threatening Illnesses and Spiritual Care, which can be found in the book by Kennedy Shelton and Jay Foss, Communication for Nurses, Talking with Patients. Thank you very much for your very informative talk, Dr. Smith. And for the audience, if you have questions, please know that you can submit them at any time by clicking in the text messaging box in the bottom left corner to type in your question, then hit send. Questions will be answered after we hear from our three speakers today. At this time, I'd like to introduce our third speaker, Dr. Lourdes Mary Santoni, who is also a 2016 Nurse Scholar of the Edmund J. Saffer Visiting Nurse Faculty Program at the Parkinson's Foundation. Dr. Santoni began her nursing career as a high school student in New York as she cared for people afflicted by illness as part of the Healing Arts program. She is a board-certified nurse practitioner, a former faculty at Drexel University School of Nursing in Philadelphia. She has an extensive neuroscience nursing career and is currently with Actify Therapeutics in Princeton, New Jersey. Dr. Santoni's work is based on the recognition that spirituality is often overlooked in healthcare, and its role in the process of reparation is a mystery. She will tell us today about her experiences and provide tips on how nurses can improve their advocacy in spirituality. Welcome, Dr. Santoni.
Glenn, and hello to everyone out there. Thank you for attending this webinar. In reviewing the literature, I found that there was little research that existed regarding spirituality and the chronic progressive illness of Parkinson's disease. I found lots of literature with regards to people with oncologic illnesses or palliative care. I also found major groups whose specialty is pastoral care, social services, education. They offer plenty of educational courses regarding spirituality, but very few with regards to the needs specifically of those afflicted with Parkinson's disease. Parkinson's affects the mind and emotional well-being and directly influences the severity of symptoms. Parkinson's isn't only a disease that affects one's motor abilities, but it also affects mentation, cognition, behavior, and mood. And this is where I think providing spiritual care to the Parkinson's community is of most importance. Spiritual assessments are not a standard of care practice for those diagnosed with Parkinson's, and spiritual practices have been found to aid the experiences of Parkinson's by including hope as a method for the Parkinson's individual to gain courage, make treatment decisions, and accept how they will live with this chronic illness. Something that's very important is that we all should be communicating and understand the words that are used and what they mean. So when looking at acronyms and the terminology used within pastoral care, spiritual care disciplines, a spiritual screen is something that almost anyone can do. It obtains data that does not change and establishes a religious affiliation. So when a patient first comes to the hospital, almost anyone obtaining the initial information and history would ask, do they have a religion? So for example, a Jehovah's Witness, once that is listed, it is clear that that individual would not be wanting any type of blood products to be given to them. The second is a spiritual history, the dynamics of how faith impacts medical care. And this is something that can change over time. So for example, someone comes in with the admission diagnosis of pneumonia, and then later it is found that they have a positive HIV status, and they really have pneumocystis pneumonia. Now this will come as a surprise and shock to the patient, their family members, and it will directly impact on how the patient accepts this life-altering change. Koenig described 5 criteria, said that any kind of assessment should be brief, easy to recall, contain the appropriate data, it should definitely be patient-centered, and it should be validated as credible. So acronyms that Koenig had used, the CSI memo, that you should be mindful of comfort, stress, influence, if your patient is a member of a spiritual community, and other spiritual needs. Poklasky and Romer's FICA model deals with the importance of faith, how that faith impacts, and how important is it for the patient themselves, whether they have a community association with a group or a member of, and actions to address. Entourage and Heights Hope is a source of hope for this individual. Are they a member of an organized religion? What personal spiritual practice do they keep? And how is this going to affect their medical care and end-of-life care issues? As nurses, we have been taught about the healing arts to validate what makes us human. The essence of nursing includes the provision of comfort, and we must attend to the emotional, physical, and spiritual needs of our patients. Nurses are very much advocates, and in the Parkinson's community, we have been able to impact not only their care, but also to be able to show what resources are required that would provide better outcomes. Our human experience includes aspects of both tangible and intangible realities to find purpose and meaning to our lives. In other words, there are things that we can actually see, taste, hear, feel. Those are the tangible things. But there are other realities that may be difficult for us to articulate. How does a patient communicate to his healthcare provider what their spiritual needs are if they are unable to find the words to express their needs? Spiritual fulfillment through others provides a sense of unconditional love and in itself is very restorative. The nurse's role includes many, many studies available to show how nurses impact patients. So in looking at spirituality, we look for truth. Our human identity is unique because we have a mind, body, and an autonomous spiritual soul. So in looking at Buddhist faith and philosophy, the first noble truth is that we are born and that we experience suffering. Facing suffering as part of life can be an aid to cope with the difficulties of not just illness, but also to strengthen our resolve and our human spirit. As the others have already said, spirituality is not religion. Spirituality is what gives us life meaning, value, and purpose, whereas religion is organized and communal beliefs and practices by a group of people. Spirituality equals loving yourself and all else. In looking at contemplative neuroscience, we look for a cause and effect. So what has been found is that life is full of challenges and subject to change. Life is dynamic. The cause of suffering is the mind's struggle in response to life experiences and the unknown. This unknown is what causes anxiety in us. Without awareness, there can be no experience. And in utilizing meditation, contemplative neuroscience has taught us and found that it is a way for us to train our mind towards self-awareness. Our self is our core consciousness and able to upgrade healing. The Buddha taught that consciousness is always continuing, like a stream of water. Mindfulness keeps us in the present moment and allows our mind consciousness to relax and let go of the energy of worrying about past or predicting future. The end of suffering is a peaceful mind and spirit, which is possible through knowledge and faith. Life is a journey, so the Buddhists tell us to follow the middle path. Life is a precious gift, and we should welcome the experiences. Life has a rhythm. We must move slowly, pay attention, be engaged with ourselves, others, and the universe. Life also has a rhythm or timeline. It has a beginning, middle, and end. And we must accept the truth of impermanence. Impermanence means that we are mindful of the fact that nothing lasts forever and there is an end. But others will say as well, the end can be a beginning. We must nourish ourselves through holistic practices where we are nurtured by both the natural and the supernatural. So that which comes to us easily that we can explain, and even those things that may come to us that have no explanation. The body is mortal, but the spirit is immortal, so it has an eternal life. We need to contemplate who we are, what our purpose is, and to live. The spiritual assessment points to remember include the fact that assessment and care are both relatable activities. The process is ongoing over time and evolves with time. We need to actively listen to our patient's life story. We need to engage with our patient's experiences. We need to encourage their expression of their hopes and fears. We have to accept our patient's strengths and weaknesses. We then integrate into theoretical frameworks of human development, philosophy, psychology, religion, and sociocultural beliefs, all of this information. We look to the patient and identify their sacred symbols and traditions. We assess them for signs of spiritual distress, grief, and loss. We provide interventions which meet their individual wellness needs, and we include family, friends, clergy, and other caregivers. In other words, we use the processes that we have in medicine and nursing and have always used all along to assess, to form a plan, to intervene, and then to reassess and check on the outcomes. I work with the community very much, and I had the opportunity to go to Lourdes, France, to the Sanctuary de Notre Dame as a medical volunteer, where I met many patients seeking wellness, not just wellness of their physical ailments or chronic conditions, but wellness of their spirit. Here is a photograph of one of the major statues at Our Lady of Lourdes in the daytime. And this is a statue, picture, same statue, but now at night. We went there to say the rosary, and there was a big chaotic confusion the next day, many people talking, did you see the picture, did you see it? I was one in the group doing the rosary at night with others, and people were taking photographs of the statue just as they do in both day and night. And as you can see from the picture, what we see is the Blessed Mother's apparition or spirit. Things like this, we have no definition for. We cannot say what we really see, what we really don't see. But those who believe and those who have faith find miracles in such places. My reference list also includes the fact that very little exists with regards to information that is out there specifically for the Parkinson's disease population. But the one thing that I definitely know from working with the community is that what we do is very important. And taking care of someone else in their most vulnerable moment is one of the most joyful experiences that I have had. And I will continue to go on pilgrimages and care for people, not just physically, but also their spirit. Thank you so much.
Thank you very much, Dr. Santoni. That was a wonderful presentation, and I'd also like to take the moment to thank Dr. Smith and Dr. Reynolds again. We will be opening up our time for questions from the audience at this time. If you have questions for any of our speakers, you can submit by clicking the text messaging box in the bottom left corner, typing in your question, and then hitting send. Our lines are now open, and we already have a few questions that we'd like to get started with. I'm going to ask this question of Dr. Reynolds, but I would like any others of our speakers to pipe in as well. In your look at the literature, Dr. Reynolds, did you run into or read anything about spiritual screening for Native American cultures? One of our listeners is interested in this.
Unfortunately, not. But this is how things begin, with the thought, how about spirituality in this culture? So this, I think, is a beautiful example of how research gets forwarded and how things change. But unfortunately, I did not find anything in the literature regarding that specific population. So I encourage whoever sent that question in to find a way to get it out there and make it known.
This is Lourdes Santoni. During my literature search, I did find the spiritual care and religious traditions by
Can you repeat the question, please?
The question was if any of our speakers had reviewed any literature on spiritual screening in the Native American culture. Dr. Reynolds eloquently says she did not, but encouraged the thought to proceed. I'm wondering if any of our other speakers have found any literature on this topic.
This is Amy Rex Smith. No, enough specifically to Parkinson's disease.
Okay.
In general, spiritual care, but nothing specific.
Okay. Let's go to our next question, and I'm going to open this to all of our speakers as well because there may be different thoughts on this. Is it possible to teach or guide patients to become spiritual?
This is Diane. I think there is a way to reawaken a spirituality or religiosity in patients, but I think the answer to that is really a philosophical one. I don't think you can write a prescription for a patient and say, hey, take this to the drugstore and you'll be a spiritual person. I don't think there are specific steps that if you do A, B, C, and D, it will help. But I think our role is more one of reawakening or finding that spiritual side. That's why I think the assessment is so very important and it can help guide that process.
This is Amy. I have I agree with everything that Diane said. I have real strong feelings about proselytizing. And because of the differential in power between the nurse and the person he's caring for, proselytizing is never ethically an acceptable option. But I think that you can be open and listen and help the patient with their own journey without imposing your beliefs in your journey.
Yes, that's a fine line, not to say, hey, I'm Catholic, this is a good path to go down. I think you make a very important point, Dr. Smith.
In fact, that was one of the questions that came through from our listening audience. Should a nurse ever share his or her own spiritual or religious beliefs with a patient?
I think if patients are requesting to know, hey, are you of a certain faith, I don't think there's anything wrong with that. But again, like Dr. Smith pointed out, there's a fine line between, communicating that and proselytizing. So I don't think there is anything wrong with that. And it may, in fact, help open the discussion.
I agree, Diane. I think you have to be if you're a good listener and you're sensitive and you're there for your patient and not for yourself, I think that you can do this in a really sensitive and, it can really be kind of a wonderful thing that happens in the nurse-patient relationship. But you have to be really, really guarding against, pushing or doing things that would not be helpful. Right. To the patient where they are.
I also think it's interesting, if patients are asking that question, they obviously want to open the discussion and talk about religion or spirituality. So I think the question itself is very telling.
Yeah. We have a question from the audience. The person writes, I am a person who was raised in a faith tradition but don't consider myself spiritual or religious. Are there ways I can offer my patient authentic spiritual care, or should I refer to a chaplain or other trained professional? And I'll open that to all of our speakers, whoever would like to answer, perhaps starting with Amy.
I'm thinking that it's really important to know that when you're entering the nurse-patient relationship, and it's very important to know where your lines are. Like if you wouldn't be comfortable praying with somebody, then you certainly shouldn't be doing that, and referral is always acceptable. But I think some of the basic interventions that were listed can be done by any nurse with whatever their personal belief system is or is not. The basic spiritual assessment, the spiritual screening, some of the FICA, some of the other things can be done. And if you're not comfortable, then referring is always a good thing to do. But I do think there's a basic level of spiritual care that every nurse can give. And then I think there's a level of spiritual care that maybe more experts in spiritual care give, and chaplains and other professionals.
I think, this is Diane, I think that the best advice I can offer that person who wrote that question, just be genuine. It sounds as though you're a caring person to begin with and are showing some interest in this topic, or else you wouldn't have participated in the webinar. So just be genuine with your patients, and I think that's the best advice I can give. But it sounds like you do have a sense of spirituality, whether or not you recognize it.
Yeah. These are two somewhat related questions I'd like to pose to our speakers. One writes in that they have found that a lot of people with Parkinson's disease are atheists. And then another question from the audience was, how do you deal with an atheist? Comments on this, please.
Well, if patients are telling you that they do not ascribe to any particular religion, I think then you can ask what have they used in the past to help them cope, and take it from there. We're certainly not trying to convert anyone, but we can certainly help with coping resources.
Absolutely, and this is Amy. One of the interesting things about nursing is thinking everyone has a spirituality, whether the person says they have the spirituality or not. And I think one atheist patient I had a very wonderful conversation with, and her spirituality was her relationship with her pet. Mm-hmm. And that was really, really important to her, and that's what gave her meaning and purpose in her life. And so to be able to support her relationship with her pet made a real difference for her. And I think that wouldn't have happened without the listening.
That we're really emphasizing here that the spirituality is really the search for meaning and purpose in life rather than a particular religion. I heard in Dr. Santoni's presentation that we can witness a lot of anxiety in our patients when they're suffering an uncertainty, and we certainly see a lot of anxiety and depression in those with Parkinson's disease as part of the disease itself. So I'm wondering from our speakers if they have any thoughts on, does one have to be well controlled as far as the depression and anxiety to really accept their spiritual being and for that to grow? Or can someone who's very anxious still have a spiritual connection?
This is Amy. I'll answer it. It seems that there's a whole school of thought in nursing that actually it's a minority group in nursing, but there's a group that feels like there's no such thing as spiritual care. There's only good psychosocial care. And this is a good example of the psychosocial care and the spiritual care, the overlap there. And I do think it's two different things, and I do think you can encourage spirituality and spiritual coping in people that have significant anxiety and depression, and people can find it very, very helpful in dealing with the whole picture of what they're dealing with. So no, I don't think you have to take care of the psychosocial problem before you address the spiritual. I'd like to hear my colleagues' answers as well.
Yeah, I agree. This is Diane. In many ways, I think that the spirituality can be used as a coping mechanism for the depression. So, it's multi-purpose. Get a lot of bang for your buck out of spiritual and religious coping.
Right.
Uh-huh.
We have another question from the audience. Are these concepts transferable to other disease processes? The person was particularly interested if these concepts apply to someone with multiple sclerosis.
I don't have specific information about multiple sclerosis, but I have done some research about spirituality in the breast cancer population, and I can tell you in the literature that I reviewed, there was an overwhelming positivity with spirituality and coping for patients with breast cancer. So yes, it can be applied to other populations, but I don't have any specific information in the patients who have multiple sclerosis.
Well, we're coming to about the top of the hour. I'd like to thank all of our speakers again today, Dr. Reynolds, Dr. Smith, Dr. Santoni, for their expertise and presence here today.